Thank you, Dr. Sharma, for that very kind introduction, and thank you to the organizers for including me in this terrific meeting. So as Dr. Sharma mentioned, today we're going to talk about HER2 low breast cancer, which is a new therapeutic subtype, go over some of the pathologic implications, the clinical challenges, and the most recent data. So HER2 low breast cancer comprises about 50% of our breast cancer cases, as you can see here. It mostly impacts hormone receptor positive disease. So you can see that small purple wedge at the bottom is the population of patients with conventionally triple negative breast cancer histology who are deemed HER2 low. But it's mostly the hormone receptor positive population that have this HER2 low status. And this is just a reminder of the ASCO-CAP guidelines for HER2 classification by IHC. HER2 positive is IHC 3+. HER2 negative historically has been IHC 0 or 1+, and in the middle we have HER2 equivocal, which is IHC 2+, which reflexes to FISH, and here are the most recent ASCO-CAP guidelines for evaluation by ISH, and you can see some examples there on the right. The top is a normal ratio of 2. The one below it is just over 12, and the one at the bottom is 6. So you can see how those probes light up, and initially it was just about the ratio of HER2 to CEP17 with the 2 cutoff, but then several years ago the guidelines were updated to include copy number as part of the definition, as you see there in that bottom row. So this led to a binary classification of disease. It was either HER2 positive or HER2 negative. And this paradigm is now being revisited as we think about HER2 low disease. And we'll talk about why in a moment. But there are some interesting observations around HER2 low disease. So there are marginal differences in gene expression between HER2 0 and HER2 low disease. So what you see here is an overall population divided at the top into HER2 0 and then HER2 low on the bottom. And that first boxed column is or hormone receptor positive disease, and that second box is triple negative disease. And you can see that the figures within a box are really similar. The amount of purple, for example, in the triple negative breast cancer group is very similar in that top pie compared to the bottom pie on the right. Indicating that biologically the HER2 0 and HER2 low are very biologically similar. So triple negative is mostly basal-like by PAM50. Hormone receptor positive is mostly luminal, as you might expect. And there's slightly more basal-like tumors among the hormone receptor positive HER2 0, but those are likely the ER low tumors, which we already know are biologically more similar to triple negative breast cancer. And what about the prognostic significance of HER2 low? So there have been a number of studies that have been conducted to evaluate the prognostic impact of HER2 low expression, and most studies have shown that there is no survival difference in HER2 low versus HER2 0 disease. So why even make this distinction? If they're biologically similar and the outcomes are the same, why does it matter? Well, HER2 testing was really developed to identify patients with HER2 positive disease. It was not developed to identify patients with HER2 low disease. And maybe the tools in our toolkit aren't optimal for identifying this new subset of patients. And maybe we should be looking at other mechanisms like combining HER2 protein analyses with mRNA, for example, or even looking at immunofluorescence to better identify these patients who are likely to benefit from HER2-directed therapy. So there are a number of challenges that we're facing right now. There's a lot of interlaboratory variability, interinterpreter variations. There have been a lot of studies showing that pathologists can't agree frequently on HER2 0 versus HER2 1+. So there's a lot of discordance in interpreter variation. There's a lack of standardization of IHC and FISH guidelines for this, and we have not yet identified the most clinically relevant definition for this subset of patients. And why does it matter? Well, in recent years, we've seen the successful drug development of antibody drug conjugates. These Today we're going to talk about antibodies that are directed to HER2. They're connected to a linker, which is in turn connected to a topoisomerase inhibitor in this case, in the case of trastuzumab deruxtecan. And what makes them potentially so compelling, or one of the reasons why they may be potentially so compelling, is that they are internalized within the cell. So the antibody binds to the cell surface, HER2, it's internalized, the linker dissolves, it releases the cytotoxic, the cell dies, and then the cytotoxic is released into the environment, thereby potentially overcoming the challenge of heterogeneity. If you only need to target the one HER2 positive cell, but everything else around it is HER2 negative, the release of that cytotoxic into the environment can kill all of those cells in the environment. So that's one of the incredibly exciting potential features of this new class of drugs. We got excited about trastuzumab deruxtecan specifically with the reporting of the Destiny-Breast01 study. So this is the first study that we saw. It was a phase 2 study. It took patients who had TDM1 resistant HER2 positive disease, so I'm not talking about HER2 low, I'm talking about HER2 positive disease, and looked at this drug, trastuzumab deruxtecan, in multiple doses, and this was the waterfall plot. I mean, I don't remember seeing a waterfall plot like this with any other study, and so incredibly exciting to see those tremendous responses in this early study. And that led to a number of other studies, including this one, Destiny-Breast03. This is the randomized study that took patients, again, with HER2 positive disease and randomized them essentially in the second-line setting to receive either trastuzumab deruxtecan or the standard of care at that time for second-line treatment for HER2 metastatic disease of TDM1. And there were a number of presentations, improvement in progression-free survival, but potentially most compelling, this massive improvement in overall survival with a hazard ratio of 0.64, so a 36% reduction in the risk of death in favor of trastuzumab deruxtecan. So this was really exciting data and displaced TDM1 in the HER2 positive setting. And so there was interest in looking at this same drug in the HER2 low population. So that led to Destiny-Breast04. This is a study in which patients with HER2 low disease were randomized to receive trastuzumab deruxtecan or physician's choice of chemotherapy. And you can see what the choices are there. Most of the patients had hormone receptor positive disease. If you remember back to that pie chart, this is a story that's most relevant to that hormone receptor positive population, but there was a subset, as you can see in the middle there, that had triple negative or hormone receptor negative disease. The primary endpoint of the study was progression-free survival in the hormone receptor positive subset. And what's notable about this study is that patients could be deemed HER2 low at any point in the time course of their disease. It could have been on the early stage diagnosis, it could have been before the first line therapy, at any point during the course of their disease. If they were deemed HER2 low, they could participate. It's worth noting that, and I just boxed the hormone receptor positive population here because that was the majority population, but you can see this is a well pre-treated population of patients with a median 3 lines of systemic therapy, a median 1 line of chemotherapy, and a couple lines of endocrine therapy. Most patients also treated with CDK4/6 inhibitors. And here's the bottom line from the study. And I don't know if any of you were at this presentation at ASCO last year. Shanu Modi did a terrific job in presenting this data, and the hall was overflowing. This data was presented, people were crying, she got a standing ovation. I mean, it was really a tremendous moment, and it was because of this data that I'm about to show you here. This is progression-free survival and overall survival in the intention to treat population, an impressive hazard ratio for progression-free survival of 0.5 and 0.64 for overall survival, and I don't think you need to be a statistician to appreciate how far apart these curves are from each other in favor of trastuzumab deruxtecan. As you'll recall, the primary endpoint for the study was progression-free survival in the hormone receptor positive subset, and that's what's shown here on the left, with a hazard ratio of 0.51, so a 50% reduction in progression and a very consistent hazard ratio for overall survival, 0.64, so a survival advantage. Now, this was an exploratory endpoint. Again, there was a minority of patients, about 60 patients who had triple-negative breast cancer who were included in the study. But again, you see a very consistent improvement in progression-free survival and overall survival with hazard ratios just below 0.5. So this led to the FDA approval of this drug. They did some subset analyses, including looking at the impact of the intervention by IHC status. So was there a difference for those who were IHC 1+ versus those who were IHC 2+ and FISH negative? And the bottom line was that there was no difference, and no difference in any of the other subsets that they interrogated. I did want to comment for a second just about toxicity. It is notable that almost 3/4 of patients participating in this study had nausea. It does require aggressive pre-medication. I had a patient, actually Dr. O'Shaughnessy and I share a patient, who we put on trastuzumab deruxtecan, and after her second cycle, she said, I don't care how great this drug is, I'm never taking this drug ever again, because her nausea and vomiting was horrific and was a really negative factor in her quality of life. So it really does require aggressive pre-medication and management. That being said, I also have a patient of Dr. Modi's who was on that original Destiny-Breast01 study, who's now 7 years out on treatment. She has no side effects. She's NED without any evaluable disease, and I struggle with how long I'm going to continue to treat her with this drug, but she has absolutely zero side effects. So I've definitely seen a spectrum in terms of tolerance with this medication, but aggressive pre-medications to prevent nausea. Another adverse event of special interest is, of course, interstitial lung disease. On the Destiny-Breast04 study, there were 3 cases of fatal interstitial lung disease in the trastuzumab deruxtecan arm. And in this study, they were doing scans, notably every 6 weeks. So based on prior experiences, with, they'd been doing scans every 9 weeks, they actually shortened the interval for scans. So these are very frequent scans, but still several cases of fatal ILD. Notably, even though this is a HER2-directed drug, there were not any significant impact on ejection-free survival and no increased incidence of cardiac failure. So I wanted to just mention a smaller study. This is the DAISY study that also looked at trastuzumab deruxtecan. And I think this is an interesting subset analysis from this trial. They looked at patients by HER2 status, specifically whether they had HER2 low or HER2 zero disease, and you can see that the numbers are relatively small, but the overall response rates are very similar between the two. And just to recall, HER2 zero doesn't mean that there's no HER2 expression at all. It just means that there isn't HER2 expression in 10% or more cells. So you can have HER2 expression in 9% of the cells and be deemed HER2 zero, and perhaps that's what explains this observation here. And I also wanted to just comment on a post-hoc analysis from the TROPICS-02 study. This was a study looking at a different antibody-drug conjugate. This is a TROP2-directed antibody-drug conjugate, sacituzumab govitecan. And this was a study that looked at that antibody-drug conjugate versus standard of care for hormone receptor-positive advanced breast cancer. And you can see what the chemotherapy options are there. So they did an interesting analysis where they looked at the impact of sacituzumab. Again, this has nothing to do with HER2, but what was the impact of sacituzumab, TROP2-directed antibody-drug conjugate, in the HER2 low and HER2 zero subset of patients that participated? And you can see a pretty consistent, again, this is an exploratory analysis, so it's hypothesis generating, but a pretty consistent benefit in the HER2 low and HER2 zero. And this is something to keep in mind when we're thinking about sequencing for these patients, because this is a question that comes up in clinical practice all the time. When do I give sacituzumab versus trastuzumab deruxtecan for my HER2 low population? This study would indicate, or this analysis would indicate, that it can be given in both of those subsets. And then it's also worth mentioning the brain metastasis population. So in the last several years, we've seen tremendous innovation in the treatment of HER2-positive brain mets. We've seen tucatinib-based regimens in the HER2 CLIMB study. We've seen impact on cranial mets with trastuzumab deruxtecan as well. So that has become, those are additional strategies in our arsenal for the treatment of HER2-positive brain metastasis. But what about HER2-low brain metastasis? And the DEBRA study aimed to attend to that. There were multiple cohorts in the study. I'm just going to focus on the HER2 cohort 2, which is HER2-positive or HER2-low with asymptomatic brain mets, and then those with progression or leptomeningeal disease. And you can see in this population with HER2-low brain mets, and it did allow patients with leptomeningeal disease, which a lot of studies don't, but you can see the impressive improvement in overall response, or not improvement rather, but you can see impressive overall response rate in these cohorts, 66.7% versus 33.3% or 50% intracranial response overall. So this does seem to be a strategy that's not only effective for the treatment of HER2-positive brain mets, but also HER2-low brain mets. So we're still faced with a number of clinical challenges, which I'll outline here. The first challenge is low concordance between IHC 0 and 1+. For example, a study of 18 experienced pathologists showed that there was only about 26% concordance in the diagnosis of HER2 0 and 1+ based on 170 breast cancer samples. IHC assays used today were developed, again, to identify overexpressing, so it's looking for the positive cases. They were not developed to look for HER2 low specifically, and may be unsuitable to distinguish this subset of patients or to distinguish them, the low from the true zeros. Again, HER2 0 doesn't mean the complete absence of HER2 protein. It might just be low and includes tumors with ultra low expression. And it's worth reminding ourselves that HER2 low status is unstable and changes over time. So there have been multiple studies that have confirmed the instability of HER2 low expression, and it's unclear why some HER2 low variability has been attributed to the pre-analytic factors, HER2 expression heterogeneity, and disease evolution. So again, in Destiny-Breast04, the seminal study that led to the approval of trastuzumab deruxtecan for HER2 low disease, patients could qualify for that study if they were HER2 low at any point in their diagnosis, whether it was 10 years ago at their early stage disease or last week when they were rebiopsied. So the optimal time point for evaluation of HER2 low status is not sure. When should we be doing it? And that is, to date, still unclear. And how low can we go? We've talked about today HER2 true zero versus HER2 low and HER2 ultra low, and we are highly anticipating the results of the ongoing Destiny-Breast06 study. This is a study that's enrolling patients with hormone receptor positive disease. That's HER2 0, defined by IHC staining, of up to 10% of tumors, so they're not truly absent in HER2, so they're in that 1 to 9% group, or 1+ or 2+, and those patients are being randomized to trastuzumab deruxtecan versus chemotherapy, and it will be really interesting to see if this ultra-low population benefits from this strategy. There's also the Destiny-Breast08 study. This is a rather complicated study enrolling patients with advanced disease that's HER2 low and randomizing them to various cohorts. Patients with hormone receptor positive or hormone receptor negative disease can participate, and they're looking at a number of different partners for trastuzumab deruxtecan. We also just saw at this most recent San Antonio meeting a presentation by Sarah Hurvitz looking at neoadjuvant trastuzumab deruxtecan. So as with other strategies where you see tremendous success in the metastatic setting, we often move those same strategies into the curative intent setting to see if we can improve cure rates and prevent metastases from occurring. And this is one of the first efforts in that curative intent space with this drug. This was a study looking at trastuzumab deruxtecan with the aromatase inhibitor anastrozole for patients with HER2 low hormone receptor positive breast cancer. And they were randomized to receive the trastuzumab deruxtecan with or without the AI before surgery. And you can see on the left, that's the trastuzumab deruxtecan alone, an overall response rate of 68%. The addition of the aromatase inhibitor to the antibody drug conjugate did not seem to confer any advantage, with a more slightly modest overall response rate of 58%. So this is potentially the first signal that trastuzumab deruxtecan will have a place in the curative intent setting, and there are certainly a number of studies that are planned largely through the cooperative groups. This is a study that was looking at central review HER2 IHC change from baseline to surgery from that TRIO talent study that I just showed you, showing that 49% of patients participating in that study had a change in their HER2 status after trastuzumab deruxtecan. So not only does HER2 status change over time, it changes in response to specific therapies, and you can see the changes there. So these are the key messages. Trastuzumab deruxtecan is available after first-line chemotherapy in the metastatic setting for patients with HER2 non-amplified and HER2 low-expressing breast cancer on any prior specimen. Prompt detection of ILD, interstitial lung disease, in patients is really important, and we have a couple minutes, so I'm just going to share a case with you very quickly. Trastuzumab deruxtecan seems to have clinical activity in CNS metastasis, as evidenced in the DAISY trial, and we are highly anticipating the results of the Destiny-Breast06 HER2 ultra-low study. But there are a number of complexities that are ongoing. We need better biomarkers to identify the subsets of patients who are likely to benefit from these strategies, as well as biomarkers that will predict for patients who won't benefit from these strategies. So I'm going to end right now just by touching on interstitial lung disease because it's so clinically important. It's characterized by ineffective gas exchange. The specific mechanisms of ILD with respect to antibody drug conjugates is not known. There are a number of theories outlined here, but truly we don't know, and there certainly have been fatal cases even with frequent monitoring. So I just wanted to go over the guidelines. This is from some of the Destiny-Breast guidelines. It recommends monitoring, and then if you look to the far right at the top, dose interruption or discontinuation for grade 1 asymptomatic disease. So those are patients who have pneumonitis only on their routine scans. So you can't capture that grade 1 disease unless you're doing more frequent scans. So in that case, you can delay the dose or hold the dose until the pneumonitis or the ILD improves. For grade 2 or more ILD, though, you need to discontinue the drug. You cannot re-challenge patients with that medication. And then you can see here some recommendations for steroids and resumption of treatment for those who have resolved grade 1 ILD. So I'm going to end now with a case. This is a 56-year-old patient with advanced breast cancer who's on trastuzumab deruxtecan, goes for scans at 6 months, and has this finding here. They have other drug-related side effects, nausea, fatigue, et cetera. But on the right, you can see that the right lung shows signs of asymptomatic disease. So I'm going to do an informal polling question right here and ask you to raise your number of fingers, 1, 2, 3, 4, or 5. So what would be the appropriate approach for a patient with asymptomatic interstitial lung disease? Do you continue trastuzumab deruxtecan at the same dose and schedule? Do you do a bronchoscopy to rule out infection or progression of disease in the lung? Do you hold the drug until ILD is resolved to grade 0 and then restart if resolved in less than 28 days? Do you give high-dose steroids and proceed to a low taper, or uncertain? So a very informal poll. Fingers. 1, 2, 3, 4, 5. That's good. I think most people picked 3, which is the correct answer. Grade 2 or more ILD, you have to discontinue permanently. Grade 1, you hold the drug until it's resolved to grade 0, and then you can restart as long as it's resolved within 28 days. So I'll end there, and thank you for your attention.